Anesthesia protocols also require the use of skeletal muscle relaxants, if anything, to get a flaccid surgical field to cut the muscle, for instance, and certainly in order to intubate a patient without running the risk of laryngospasm and potential injury. Skeletal muscle relaxants, if you recall, this section whereby we're looking at drugs working on the nicotinic acetylcholine receptor of the neuromuscular junction. This is a little section at the end of the autonomic nervous system in the cholinergic pharmacology, where we had announced at the time, let's wait until we're in the CNS section to talk about drugs that work on this subtype of nicotinic receptor. It is the receptor that we've referred to previously as NM, M for muscle. Well, it is a ligand-gated ion channel. As usual, it is made then of 5 subunits, and as you look at these 5 subunits, you are noticing that there are 2 alpha subunits. These alpha subunits must be bound to conjointly by 2 acetylcholine molecules in order to open a channel that is then selective for sodium and potassium conductance. Now, we know that as soon as we open a channel on any cell in our body, sodium will get in, while potassium will leave that cell, and in this case will result in depolarization of the skeletal muscle. The idea of a skeletal muscle relaxant is to prevent the depolarizing action of acetylcholine on its alpha subunits of nicotinic M type of receptors. The idea of antagonizing the effect of acetylcholine on this receptor is to prevent the depolarization from reaching threshold and prevent therefore the firing of an action potential that could result in the contraction of this skeletal muscle. There will be 2 groups of drugs interfering with the nicotinic M type of receptor. First, we're going to look at the competitive antagonists of acetylcholine, also known as non-depolarizing drugs. These nicotinic receptor antagonists are represented by the prototype D-tubocurarine. D-tubocurarine is the principal alkaloid of curare preparations. You know, curare preparations are used in South America as hunting poisons, which importantly are placed at the tip of arrows and then can be used to actually immobilize a prey in order to bring it back and eat it. Now, I suggest you might want to buy a nice blowpipe from somewhere in South America and blow a dart at the butt of your patient if you need to. You'll probably get arrested though. As a prototype, it's a very, very potent neuromuscular blocking drug. And as such, it's more a basic structure from which to derive analogs that are more conventionally used clinically, such as drugs that end up in curonium or curium. And we'll see a couple examples of those in a second. But before we get too far, what is the efficacy of an antagonist? I'm sure you're saying 0, and you're absolutely correct. Because these drugs are blockers, they have no effect. This is why they're referred to as non-depolarizing drugs. In their mode of blocking, they are competitive inhibitors. Therefore, on this diagram, where would you imagine D-tubocurarine would be binding to? If you're saying the alpha subunit, you are absolutely correct. This is where curare-like drugs would be binding to, blocking the access of acetylcholine to its receptor. Well, as I'm looking at this, I certainly remember there are 2 alpha subunits. So here is a very silly board question that we know of, which is how many molecules of curare-like drug would you need in order to cause skeletal muscle relaxation? I'm sure some of you said 2, and you fell in the trap. Since you need 2 acetylcholine at any given time to open the channel, a single molecule of blocker will do the job of preventing at any time the binding of 2 acetylcholine at the same time on the channel. So 1 molecule of blocker is enough to prevent the effect of acetylcholine on its receptor. These drugs will be competitive antagonists. They are therefore reversible. And the way to reverse competitive antagonists, as we know, is to increase the actual normal ligand for the receptor. How could I increase levels of acetylcholine to kick the curare off of its binding site? You know, We've seen it already, indeed, in the autonomic nervous system. This is the job of acetylcholinesterase inhibitors. So your third bullet point saying that the blockade is reversible with acetylcholinesterase inhibitor is probably one of the most important one in this section, reminding us that then for an emergency or operating room type of medication, we actually have an antidote. Now, a common acetylcholinesterase inhibitor is a drug ending up in stigmine. And I must ask you to remind me, why would I choose neostigmine over physostigmine in order to reverse this block? Well, I think you're absolutely right. The idea is that physostigmine would cross the blood-brain barrier as a tertiary amine and cause CNS toxicity. We do not have skeletal muscle in our brain. There is no need for a drug crossing the blood-brain barrier. Neostigmine as a quaternary amine would remain in the periphery. And how about this one? Why not hydrophonium? Well, absolutely. Hydrophonium you would not use because it's too short-acting. The reversal would be so short-lived that really the blockade would come right after the efficacy of the drug would have finished. So maybe you want to remind yourself a little bit of what hydrophonium is used for. And indeed, it is the diagnosis of myasthenia, including the differential diagnosis of myasthenia with cholinergic crisis. In this situation, we have a good skeletal muscle relaxant that can be reversed with a simple drug such as neostigmine. Let's talk about the paralysis. You know, remembering myasthenia is pretty relevant here because we'll observe a progressive paralysis. First, the facial muscles will be affected, exactly like in the disease myasthenia with facial muscle weakness, ptosis. Then the limbs, and ultimately, but invariably, respiratory muscles such as the diaphragm, meaning clearly there is absolutely no way, unless you wanted to kill someone, to use these medications without the intent of mechanically ventilating and supporting this patient. Well, here's an important point. Nicotinic receptor M type are only found in skeletal muscle. So these are drugs that will have no effect on the heart, no effect on the smooth muscles of GI, vessels, and so forth. And further, they will have no central nervous system effect. Now, we both know that when we try and check the consciousness level in a patient, we might ask questions such as, what is your name? Can you hear me? Can you blink an eye? Can you grab my finger? What happened to you today? And so forth. Imagine this. This patient has an intact sensorium. This patient can hear you. This patient can remember what goes on. They can see you if their eyes are open. And they can definitely feel pain. But they are trapped in a body in which every muscle fiber is paralyzed. Never forget to give these patients adequate anesthesia, analgesics, sedative, all the actual drugs that go in classic protocols. Otherwise, you're going to have a very unhappy patient when they wake up. Most often, when people recall well what happened in emergency room is when they were under the influence of these drugs and sometimes live virtual nightmares or literal nightmares because of not being adequately medicated with relevant sedative and analgesics. So no CNS effect, no cardiac, no smooth muscle effect, just skeletal muscle relaxation. Well, looking at non-depolarizing competitive blockers here, we've decided on two drugs over the years that are classically board tested, the drug atracurium and the drug mivacurium. They each have two little points that you may want to know practically in their use. Atracurium is pretty rapid in its action, but its key point is its safety in hepatic or renal impairment. See, when we think about it, our patients who arrive in emergency room do not come with a tag telling us, oh, by the way, my liver is diseased or my kidney function is not very good. So when we can find a drug that actually is safe because it is neither metabolized by a kidney nor a liver or excreted by such organs, then I'm most happy. This is the case for atracurium. That's the point to remember. What is the second point? The second point is how come it is not metabolized? Well, this is because it spontaneously breaks down, that is, by itself, a chemical reaction that is non-enzymatic, to a chemical called lodanosine. And here's the issue, though. lodanicine can cause seizures. So if you wanted a side effect of atrocurium, this is a skeletal muscle relaxant. Nonetheless, when the patient comes off of the skeletal muscle relaxation, seizures can occur because of the breakdown product of lodanicine. Some of you might have heard, particularly in medical school, of that spontaneous inactivation. It is an organic chemistry reaction known as a Hoffman degradation. And Hoffman degradation, we certainly don't need in medicine to know the ins and outs of it, but it's just in case you see the terminology and wonder what is being referred to for a drug such as atrocurium. How about mivacurium 2.2? This is actually an ultra-short acting drug which owes its actual speed to the metabolism by esterases. Okay, they're called choline esterases. Actually, in some book, they're called butyrylcholine esterase or pseudocholine esterase. You know, I really don't care about anything in front of esterase because to me in medicine, if I see the word esterase, I know its significance. It is the fact that there are slow and fast metabolizers. And you know, in talking of very short duration, who do you think this applies to? Of course, the fast metabolizer. If one of your patients happens to be an unlucky slow metabolizer, forget about that very short duration of a drug like mivacurium. How about the other group of drugs? The other group of drugs are basically drugs that are depolarizing. Now, when you see the word depolarizing, you expect an effect of the medication. And indeed, the effect is to be given by a nicotinic agonist. Easy to recognize, it's an agonist. The prototype is the drug succinylcholine. Notice how it sounds like acetylcholine. This is not a blocker. This is an agonist of the receptor. So how could stimulation of a receptor result in actual paralysis? Well, we must remember that nicotinic receptors desensitize extremely quickly. So the job of the drug succinylcholine is to bind to the receptor, stimulate it, but stimulate it in such a way for so long that the system desensitizes. In effect, what we're trying to do with succinylcholine is a cholinergic crisis. You remember the cholinergic crisis? We talked about it during myasthenia. So succinylcholine as an agonist, for one, is not going to be competitive. Imagine this, the phase 1 is that of depolarization. It might even result in fasciculation, visible muscle contractures. But then ultimately it will result in flaccid paralysis from the phase of desensitization. Let's try and compete for desensitization. Giving an agonist to try and restart the muscle would only worsen the process. As such, acetylcholine esterase inhibitors would worsen phase 1, increasing the risk for fasciculation, and certainly never reverse phase 2 of desensitization. They have no effect on phase 2. They might even worsen the actual desensitization block. In turn, giving a blocker would never help either. Blockers have zero efficacy and in and of themselves would result in muscle paralysis. So how can I get rid of the effect of a chemical that works through desensitization? Well, I will depend totally on the rapid metabolism of succinylcholine, and its metabolism, of course, is thanks to esterases. Now here, if you want to remember choline in front of it, of course you could. It's not acetylcholine esterase because we're talking succinylcholine, so we call it pseudocholine esterase. Thanks to this esterase, we should see a very short duration of the drug succinylcholine, but we must remember some people may be atypical for cholinesterases. Atypical meaning they are slow metabolizers, and when you're a slow metabolizer, the effect of succinylcholine would be there to stay. Besides that, never forget that hyperkalemia could worsen depolarization, and as such, hyperkalemia could actually enhance the effect of succinylcholine. When you think of this, it means that now your patient may require to stay intubated for a longer period of time. Intubation is not only costly, it is often life-threatening in our hospitals because of multi-drug resistant aerobic bacteria such as Pseudomonas. So we never benefit from too long of an effect of the drug. Finally, and most relevantly, we must think of the drug as a cause of malignant hyperthermia. Malignant hyperthermia is actually reviewed in your margin. So let me help you switching program here and taking a white page in the process of malignant hyperthermia. The initial problem and initial issue is the fact that succinylcholine depolarizes muscle. And if it depolarizes muscle and is given IV, every muscle fiber in the patient's body can now undergo contraction. And the cycles of contraction and relaxation always need lots of ATP. So there is a sudden increased demand on ATP for that contraction relaxation cycling of the actin-myosin, meaning it's going to have to increase electron transport. Increasing electron transport chain does mean increase oxygen consumption, and also means, just like good old exercise, that you have to increase metabolism, which will cause acidosis, metabolic acidosis, and also will dissipate some energy as heat. So now you have a patient who is starting to heat up as if you were running on a treadmill because of all the muscle contraction, and a patient who is developing significant acidosis. If the heat becomes big enough, malignant, then this in turn will trigger an increase in sympathetic autonomic nervous system response in order to try and increase sweating and cooling of the body. But that alone will result now in increased heart rate, the potential for arrhythmias, certainly the potentials for hypertension. And you put all this together, you now have a patient who is in a life-threatening condition we call malignant hyperthermia. Now, this is a patient who probably has as a background an autosomal dominant disorder of the muscle. And the autosomal dominant disorder of the muscle, which you find in more than 50% of these patients, is actually a mutation in the ryanodine receptors. Ryanodine receptors, if you recall your physiology, are important on the sarcoplasmic reticulum and control the levels of calcium in the SR. These are patients who end up with so much calcium in the sarcoplasmic reticulum, upon depolarization by succinylcholine, they have a huge amount of calcium in the cell. Therefore, they tend to have a huge contractile response, and their risk of malignant hyperthermia is that much greater. Well, know well the antidote dantrolene that is mentioned in your margin. Dantrolene is considered an antidote because dantrolene prevents the calcium release from the sarcoplasmic reticulum. We'll talk more about dantrolene also in neuroleptic malignant syndrome. Final slide is reminding us that we can centrally relax skeletal muscle, in particular through benzodiazepine and GABA-A receptors, and let's not forget the GABA-B receptor agonist baclofen used in spasticity. This concludes Chapter 4, Drugs Used in Anesthesia.